Right now, across the globe, there are patients paying thousands of dollars to inject dermal fillers into a part of the human anatomy that, well, highly credentialed sex researchers actually refer to as a gynecological UFO.
A UFO,
Mm.
which is quite the visual.
Right, meaning, there have been plenty of reported sightings over the decades, but its distinct, isolated anatomical existence is still entirely unconfirmed by modern science.
Exactly. It's a massive gray area.
So, welcome to the deep dive. Today, we are taking you on a journey into the highly controversial, rapidly expanding world of female genital cosmetic surgery, or FGCS.
And it is booming right now.
It really is. Specifically, our mission today is to explore the ethical guidelines that govern medical professionals when a patient asks for a repeat G-spot augmentation, especially when they might actually be suffering from, unaddressed psychosexual or relationship distress.
The tension in this space is just palpable.
Uh,
We are analyzing a stack of sources today that basically put the booming commercial market of cosmetic surgery on a direct collision course with the rigorous world of medical ethics.
Yeah, we've got some heavy hitters in the sources today.
We do. We're looking at official committee opinions from the American College of Obstetricians and Gynecologists, which is ACOG, plus guidelines from the Royal Australian College of General Practitioners.
And some international plastic surgery ethics frameworks, right?
Right, alongside these really deep psychological reviews on female sexual health.
Okay, let's unpack this. Because before we can even begin to understand the ethics of a doctor performing a repeat procedure on a vulnerable patient, we need to understand what this procedure actually is.
And the intense anatomical debate surrounding the target area itself.
Yeah, the history here is wild. The term G-spot stems from a German gynecologist named Ernst Grafenberg back in 1950.
Right, he hypothesized there was this distinct erogenous zone along the anterior vaginal wall linked to urethral stimulation.
But the irony is, he didn't even name it after himself.
No, he didn't.
That didn't happen until the 1980s when Adiego and his team branded it the Grafenberg spot, which really shows how modern this whole cultural fixation actually is.
What's fascinating here is how the current medical consensus sharply diverges from that 1980s branding.
How so?
Well, despite decades of searching with, advanced imaging and histological studies, scientists have not found a discrete button-like structure in that anterior wall.
So the button doesn't exist.
Not like people think. The literature we're reviewing leans heavily toward a model of a clitoris or vaginal complex.
That is a mouthful.
It is, yeah.
Yeah?
But it basically represents a highly interconnected neurovascular network where the internal bulbs of the clitoris, the urethra, and the anterior vaginal wall all converge.
Got it.
It's highly functional, rich in nerve endings, but it is a complex regional system. It's not a singular, isolated organ you can just map with a pinpoint coordinate.
Which brings a massive dose of reality to the mechanics of the G-shot, or G-spot amplification.
Yeah, the mechanics are where things get really controversial.
Right, because this procedure involves injecting materials like medical-grade collagen or cross-linked hyaluronic acid or even platelet-rich plasma directly into the vesicovaginal septum.
Which is the tissue wall between the bladder and the vagina.
Exactly. And functionally, they use cross-linked hyaluronic acid, or HA, because the cross-linking process binds the molecules into this sturdy, viscous gel. It resists enzymatic breakdown.
Theoretically creating a longer-lasting physical bulge.
Right. And then you have platelet-rich plasma, or PRP, which is injected under this unproven premise that its localized growth factors will trigger angiogenesis and neurogenesis.
Basically meaning they think it'll grow new blood vessels and nerve endings in that septum to heighten sensitivity.
Yeah. But honestly, injecting a highly viscous cross-linked filler into a fiercely debated, basically invisible anatomical network, it sounds like trying to put a tailored suit on Bigfoot.
A tailored suit on Bigfoot. I love that.
I mean, you are spending a massive amount of money to enhance something that rigorous science isn't totally sure exists in the isolated way you think it does?
No, they are definitely not sure. The core mechanism the practitioners are aiming for is structural augmentation.
Right, just making it bigger.
Exactly. By increasing the size, thickness, and protrusion of that specific anterior wall region, the theory is that it increases targeted friction during intercourse, thereby heightening pleasure.
But the data doesn't back that up, does it?
Not at all. ACOG's stance on this theoretical mechanism is unambiguous. Their committee opinions explicitly state there is zero high-quality, peer-reviewed data supporting either the safety or the efficacy of these augmentations.
Wow. Zero data.
Zero. And beyond the lack of data, ACOG points out that terms like vaginal rejuvenation or the G-shot are entirely commercial inventions.
They're marketing terms.
Pure marketing.
Yeah.
They are completely disconnected from recognized medical diagnoses.
And didn't the FDA step in on some of this?
They did. The FDA went as far as issuing warnings against using energy-based devices for these unproven cosmetic purposes because of the risk of thermal burns, scarring, and chronic pain.
That's terrifying.
It is. The commercialization of the terminology is a deliberate strategy. It reframes normal anatomical variation as a medical deficit that requires a commercial intervention.
So they're creating a problem to sell the cure.
Exactly. And when we look at the skyrocketing demand, our sources show labiaplasty rates in the U.S. jumping over 50% in a 4-year span recently. We have to look at the cultural drivers that are basically stripping away the camouflage of normal anatomy.
Grooming habits are the first major domino there, right?
Huge domino.
Because the normalization of complete hair removal, like laser hair removal and electrolysis, means the genitalia is entirely visible on a daily basis.
Right, there's nowhere to hide.
You remove the hair, and suddenly the natural asymmetries that were always there become these hyper-focused focal points.
And the human brain is tricky. When it's constantly examining a highly visible area under the influence of skewed baseline data, it starts interpreting normal biological variation as a structural flaw.
And that baseline data is heavily corrupted by digital media and pornography.
So corrupted. The sources emphasize how these platforms promote a highly curated, often digitally altered, prepubescent ideal of female genitalia.
It's the myth of the perfect vulva.
Yes. And visual processing of this repetitive media actually warps a patient's internal schema of what constitutes a normal vulva.
So when a patient compares their natural adult anatomy to an algorithmically optimized image,
the resulting psychological dissonance drives them straight to a cosmetic surgeon's office.
it makes sense. But what's the fix? The antidote recommended by the Royal Australian College of General Practitioners is this aggressive educational counteroffensive.
Right, they want to re-educate.
They urge clinicians to direct patients toward resources like the Labia Library or the art installation, the Great Wall of Vagina.
Which are incredible resources, by the way.
They really are. They bypass all the clinical jargon and just provide raw visual proof of the massive diversity in labia minora length, clitoral hood structure, and pigmentation. It recalibrates that warped internal schema back to reality.
Which is exactly what needs to happen.
But let me play devil's advocate for a second.
Yeah.
If I'm looking at this from the perspective of a listener who just feels deeply insecure,
Sure.
If a quick injection of hyaluronic acid or a minor surgical trim will instantly alleviate their psychological distress and boost their self-esteem, why is the medical establishment putting up so much resistance?
That's the big question.
If it grants them confidence, why not just perform the procedure?
Because capitulating to that request fundamentally breaches the ethics of non-maleficence by medicalizing a completely normal appearance.
Oh, okay. Unpack that a bit. Non-maleficence.
It means do no harm. When a clinician agrees to surgically alter or inject healthy, functional tissue solely to appease a culturally manufactured insecurity, the medical system is implicitly validating the patient's false belief that their natural body was defective.
Oh, wow. I never thought about it like that. By doing the surgery, the doctor's saying, yeah, you were broken.
Exactly. Furthermore, the longitudinal studies in our stack demonstrate absolutely no proven, sustained link between the aesthetic appearance of genitalia and long-term sexual satisfaction.
So it doesn't even work long-term.
No. Altering the physical structure does not rewrite the neural pathways of self-esteem.
It's the classic trap of trying to solve an internal crisis with an external intervention,
Perfectly said.
which forces us to look at the hidden agony beneath the surgical request.
Right. Yeah, this is where it gets heavy.
The desire for a G-spot injection often serves as a physical mask for a much more complex biopsychosocial issue.
Right. One of our sources perfectly encapsulates this. They note that sexual function is as dependent on the brain as it is on the sexual organ.
It's all connected.
The entire system is an interconnected web of neurobiology, psychology, and relational dynamics.
So when a patient requests a physical enhancement to resolve a sexual dysfunction, they're often unknowingly dealing with underlying conditions that just mimic the need for a structural fix.
Exactly. Consider dyspareunia, which is painful intercourse, or vaginismus.
Which is the involuntary muscle spasm, right?
Right, involuntary hypertonic spasms of the pelvic floor musculature. Now, imagine a patient is experiencing that, and a doctor injects a space-occupying gel, like cross-linked HA, into the vaginal wall.
That sounds like a terrible idea.
It is catastrophic mechanically. Adding volume to an area that is already aggressively guarding stretches hypersensitized tissues. It amplifies the nociceptive nerve signals and drastically exacerbates the pain.
You're literally making the pain worse by trying to fix it with a filler.
Yes.
And we can't ignore the relational environment surrounding that pain either.
No, we really can't.
Our sources highlight a deeply troubling dynamic where patients feel subtly coerced or obligated to engage in sexual activity just to maintain a relationship.
This is a huge factor.
When a person is engaging in intimacy out of obligation rather than genuine desire, the physiological arousal cascade simply does not trigger.
Where the tissues don't engorge.
Natural lubrication fails, and the inevitable result of that mechanical friction is pain.
And so the patient internalizes this, right? They think, I'm broken, I can't feel pleasure, I need a structural augmentation.
When in reality,
Their body is actually functioning perfectly by rejecting an unsafe relational dynamic.
wow, their body is working exactly as it should to protect them.
This raises an important question. How does a clinician effectively separate a harmless aesthetic request from a profound cry for psychological intervention?
That has to be incredibly difficult in a 20-minute consultation.
It is. Because on the purely psychiatric front, a significant cohort of these patients meet the clinical criteria for body dysmorphic disorder, or BDD.
Which is much more severe than just low self-esteem.
Oh, absolutely. It is an obsessive, debilitating preoccupation with an imagined or slight physical defect.
Right.
The literature shows these patients exhibit severe safety-seeking behaviors, compulsive mirror checking, constant reassurance seeking, or total avoidance of intimacy.
So if a doctor injects filler into the anatomy of a patient suffering from BDD or relational coercion or trauma,
They are not just failing to treat the dysfunction, they are actively reinforcing the psychological pathology.
which brings us to the absolute core of our mission today, the ethical boundary of the repeat procedure.
This is the real test.
The initial surgery is a massive ethical hurdle on its own. But the true test of medical integrity occurs when a patient gets that first G-shot, and predictably, their marital distress or their BDD doesn't magically evaporate.
Because of course it doesn't.
Right. And so they return to the clinic deeply unsatisfied, requesting a second or third round of augmentation, convinced that the first dose just wasn't enough.
This phenomenon is known in the literature as serial escalation.
Serial escalation.
Yeah. And the guidelines from international plastic surgery ethics frameworks are universally stringent on this point.
They don't mess around here.
No. A repeat request, shifting anatomical concerns, or persistent dissatisfaction following a technically adequate primary procedure must act as a hard stop.
A hard stop, like do not proceed.
Exactly. It should immediately trigger a comprehensive psychological review. The prevailing ethical doctrine is that revision or repeat augmentation is a clinical indication, not a consumer entitlement.
I love that phrasing. Just because the patient is willing to swipe a credit card for an elective procedure doesn't mean the physician is absolved of their ethical duty.
Not at all. The repeat procedure must pass through the exact same rigorous ethical filter as the primary intervention.
And the official bodies, like the Society of Obstetricians and Gynecologists of Canada, SOGC, and ACOG, have structured mandatory screening protocols to enforce this.
They have. The clinical pathways outlined in the SOGC guidelines demand a forensic level of history-taking before a practitioner can even consider a secondary elective intervention.
What does a forensic level look like in practice?
Well, they are required to assess the full biopsychosocial spectrum. This means ruling out active intimate partner violence, ruling out coercion, and employing validated screening tools like the BDD questionnaire.
So they have to actually test for the dysmorphia.
Yes, the practitioner must ascertain the exact mechanical or psychological reason for the dissatisfaction.
And if they found red flags?
If the patient is spending hours a day agonizing over an invisible anatomical complex, or if they hold the belief of their defect with delusional intensity, the guidelines dictate an absolute contraindication for further surgery.
Meaning no more needles.
None.
Here's where it gets really interesting, because we have to map these sterile written guidelines onto the messy reality of a private medical practice.
Right. The real world is complicated.
Picture this. You are a physician in a fee-for-service cosmetic clinic. A patient is sitting in your consultation room, emotionally distraught, practically begging for a repeat G-spot injection.
Because they're thoroughly convinced this physical augmentation is the last remaining lifeline for their failing marriage.
Exactly. And the procedure is highly profitable. It takes maybe 20 minutes, and it carries relatively low acute physical
In the
risks.
short term, sure.
But according to the rigorous ethical frameworks we are analyzing, you are ethically bound to look that desperate patient in the eye and deny them the service.
If we connect this to the bigger picture, true medical ethics demand a multidisciplinary approach to patient care.
So you don't just say no and kick them out.
No. Denying the surgical intervention is not synonymous with abandoning the patient. In that highly charged scenario, injecting hyaluronic acid is a violation of non-maleficence because it perpetuates a harmful illusion.
Right, it feeds the delusion.
The ethical, evidence-based treatment is a strategic referral.
The practitioner has to step out of the surgical silo.
Yes.
They need to seamlessly transition that patient to a specialized network, like a certified sex therapist to address the relational coercion.
Or a pelvic floor physical therapist to mechanically address the hypertonicity causing the pain.
Right, or a clinical psychologist to initiate cognitive behavioral therapy for the underlying body dysmorphic disorder.
The primary duty of the clinician in that moment is to validate the visceral reality of the patient's emotional response.
That validation is so key.
It is. If a patient is weeping in your office over vulvovaginal pain or profound emotional numbness, you must validate that their distress is absolutely real.
But you can't feed into it.
Right. Professional integrity requires the clinician to refuse participation in a delusion. You cannot pretend that localized tissue expansion will repair a fractured marriage or rewire a neurobiological body image disorder.
The international guidelines are incredibly explicit on this, aren't they?
Incredibly explicit. Commercial conflicts of interest or the financial incentives of a booming aesthetic market must never, under any circumstances, override the objective assessment of a patient's true psychosocial needs.
That requires an extraordinary level of professional courage.
It really does.
The practitioner has to be willing to absorb the immediate anger of a disappointed patient and willingly forfeit the financial revenue of that procedure, specifically to protect a vulnerable person from the long-term psychological damage of serial escalation.
Which is hard to do when there's money on the table.
It's about putting the needle down and having the difficult conversation that recognizes sexual health as an intricate, interdependent web, not a mechanical button you can just inject and press.
And in a hyper-commercialized landscape, where marketing algorithms constantly push the narrative of the quick surgical fix, holding that ethical line is more critical.
And arguably more difficult.
Exactly. More difficult than ever before. This is exactly why these rigid ethical frameworks like those from ACOG and SOGC exist.
They're the safety net.
They serve as a vital guardrail against the weaponization of medical technology for profit at the expense of psychological well-being.
So what does this all mean? Let's distill the core insights of this deep dive.
We've covered a lot of ground today.
We have. We are navigating an era where aesthetic gynecology has exploded into a multi-million-dollar global industry, propelled by aggressive digital media and shifting cultural standards of grooming. Yet the specific target of the procedures we explored today, the G-spot, remains a biological enigma, understood by the scientific consensus as a highly complex neurovascular network rather than a distinct augmentable organ.
That's the key takeaway on the anatomy front.
We've uncovered that true sexual health cannot be isolated to physical anatomy. It is a deeply intertwined biopsychosocial web.
Beautifully said.
And when patients find themselves trapped in a cycle of seeking repeat physical augmentations for what is fundamentally unaddressed psychosexual dysfunction or relationship distress, the ethical guidelines leave no room for ambiguity.
Not at all.
Practitioners are ethically mandated to put down the needle. They must prioritize comprehensive mental, emotional, and relational care over highly profitable, scientifically unproven physical alterations.
It serves as a necessary grounding reminder that not every human struggle has a surgical solution.
Sure.
The most profound, lasting healing almost always occurs in how we process our trauma, how we communicate our desires, and how we relate to our own bodies, not in how we attempt to superficially alter our physical architecture.
I want to leave you with a final thought to mull over as you step away from this material.
Okay, let's hear it.
Imagine for a moment that tomorrow, medical science actually did achieve the impossible and invented a flawless, guaranteed, 100% effective physical fix for sexual pleasure.
A true biological magic bullet.
Right, one that functioned exactly as the marketing brochures promise. If we had access to that technology today, would it actually improve the overall quality and depth of our intimate relationships?
Ooh, that is a tough question.
Or would a guaranteed physical response just painfully expose the deep emotional disconnects, the lack of vulnerability, and the communication breakdowns that we were trying so desperately to bypass with a syringe?
Something to really think about.
Thank you for joining us on this deep dive. Keep questioning the world around you, keep looking past the surface, and we'll see you next time.